Thank you.
Thank you very much, Madeline. Let me begin by saying, when we asked Robin if she would facilitate our program today and be our speaker, we had no idea what might be coming down the pike. And I would tell you that I had this vision of bad things happening, but that's not really true. That's not my nature. On the other hand, I don't think we could have a pair of speakers that are any more time and issue appropriate than these two folks that we've got today. We have Robin Knobling, who is the Executive Director for the National Alliance on Mental Illness, also known as NAMI. And she is partners, or the group is partners in, okay, this is redundant, Partners in Care task force, which basically means that she is working with another group, and that group is Partners in Care. And the other person that we have today on our program to talk about the issue of mental health issues and the police force is Mike Randolph, who is the supervisor and the coordinator with Metro Nashville PD on issues that have to do with what happens when you end up in a situation or a potential situation where there's going to be some mental health issues and you're a policeman that doesn't know much about mental health. And so Mike Randolph has been working hard to, well, and Robin, they both been working hard to help the people that are in law enforcement in Middle Tennessee become more acclimated to dealing with people with mental health issues. And I think in defining and describing and understanding what mental health issues are out in the community. And they do that in several different ways. And I'm really excited for them to tell you about it, because it's a lot more than you just might think. It's not just a psychologist in the car with the police. So with that as my rudimentary introduction, I'm going to turn it over to the two of you to share with us all of your information. And we're so excited to have you here, particularly right now.
Well, we appreciate the invitation, and I want to thank Jack. Jack and I go back a ways, and he was the one that brought us to your attention. So thank you, Jack. Mike and I go back a ways, and I'm going to give just a little bit of background on this leading up to Partners in Care, and then the role of NAMI. And then I'll let Mike take over, because he's the one that is neck deep in this, and he's the one that can really fill you in on what we've been doing. So I serve as the executive director of NAMI of Davidson County. I've done that for 10 years. We're a national peer-to-peer organization. That means anybody in the organization either has the direct lived experience of a mental health condition, or they love somebody that does. And so we're the largest peer-to-peer organization that does that. And in and around Davidson County, there, we primarily, our goal is to serve Davidson County, but 30% of the people that come to us come from outside of Davidson County. And we're the direct service provider, meaning we're doing the support groups, the training, the community collaboration, the caregiver education, lived experience education, a number of things. We cross all ages, all stages, all cultures. And so one of the things that we are involved in NAMI, we provide support, education, advocacy, and awareness. And this particularly falls into what we consider justice advocacy. We have been involved, or I have been involved, as you know, with our agency for years. I sit on the Mayor's Behavioral Wellness Advisory Council, and I also sit on the Community Mental Health Services Initiative. And those two agencies, those two groups in particular, have been working very, very hard to decriminalize mental health and to move people into care rather than into jail for a medical condition that they have that shows itself behaviorally very frequently. And so in our role in those two organizations, and I really appreciate those organizations because they are well staffed collaboratively with people from all walks. There are people in the mental health system. There are people in the justice system, which is inclusive of the courts and inclusive of the sheriff's department and the police department. The schools are involved. Homelessness is involved. Drugs and alcohol, lived experience peers. We help to represent families that might come into contact. And there's just a nice broad array. The public defender's office is involved. There's just a really good broad array of people, and of course, mental health providers that have been looking at this issue and going, how can we do this? What's the best way to look at this? And so we, over the years, have looked at many, many models around the country that are doing this for ways that, first of all, we had to decide what's diversion. What does diversion mean to us? Because in NAMI, it means something different than it might in the school system, than it might in the jail system, than it might in. So first of all, we had to come together and define that through facilitated discussions. We had many, many facilitated discussions. Then we kind of gotten down and nailed down, we really would like this. Then we had the work of, making sure that everybody was on board with it. Michael and I have worked in the past. We so appreciate Crisis, the Crisis Stabilization Unit out of the Mental Health Cooperative, the mobile crisis workers. We've had many times to come together with situations. And so I've always appreciated Mike's expertise. But once the committees got done with their work, then it came down to how to. And so the health department is very involved with this. So a pilot program was developed and Mike was tasked with carrying that out. So I am going to stop at where we were, kind of bringing this to the forefront, and let Mike pick up and tell you about all the hard work he's been doing.
Thank you, Robin. So, yeah, when we started looking at what kind of pilot program we wanted to launch, we started looking at different cities that may have already started doing work like this. And I apologize for my dress and my mask and stuff. I'm at the actually, we just came in from a call, and I'm actually helping get a guy placed in treatment right now. And then I taken a time out to do this presentation. So we actually found Denver was a city that was similar size to us, with a model and a program that we really like. They have a co-response model that really spoke to us. It kind of solved some of the problems that we were struggling with designing the program. So our program is a pilot program. It's in North Precinct and Hermitage Precinct. And we have 6 full-time mental health clinicians. They work, 4 of them work 10-hour shifts at their details. And details is like day shift, evening shift, night shift. And we are there from the day shift and the evening shift. So from 6:30 in the morning till about midnight, we have a clinician in North Precinct and Hermitage Precinct. They show up every day for roll call, which is when they do all the officers do their meeting, the patrol officers, and then they're assigned to one of the officers that we actually have trained. And that's a big component here, is that all officers in the program go through a 40-hour CIT-like training that Robin graciously helps us put on, where they learn a lot of topics about mental health diagnoses. They learn about how to de-escalate communication. They get a lot of education about that. We have a lot of guest speakers come in about lived experience and trauma-informed care. And then we do a lot of in-classroom de-escalation scenarios with mental health issues. And we also try to do some more realistic scenarios with mental health issues. And after that class, we feel that they're ready to ride with the clinician. So when the clinician and the officer are teamed up, that car primarily responds to mental health calls, but they also can respond to any other calls that come up. Generally in a partners in care situation, the officer will secure the scene, make sure things are safe for the counselor. And that can be a quick process that can only take, just a glance by the officer. Sometimes it takes multiple officers, but generally very quickly the scene is secure and the counselor can start engaging with that person and kind of de-escalating them. And it's really nice to have an officer and a clinician together, because some people really like mental health professionals and prefer to talk to a mental health professional. We've also come across people who don't like talking to mental health professionals and they'd rather talk to the officer. And as a group, we were able to kind of make a plan there. We started the program training for low-level crises like to high-level crises such as suicidal ideation and psychosis. And so far, our numbers have been more acute than we were thought they would be, which means in our language that we're going on more serious calls than we thought that we would be going on. So we've had about 840 incidents so far through second quarter. We've answered, I believe, like 1,600 calls total, but out of those calls, 840 were mental health related. And about 45% of those, I don't have the numbers super in front of me and I should memorize these for talks like this, but about 45 of those needed a full crisis assessment. And what I mean by full crisis assessment is that they were possibly at imminent risk to harm themselves or others. So that means someone who is possibly suicidal. It could be a psychosis, which means it could be somebody who's schizophrenic, hearing voices, delusional to the point where they might be able to take care of themselves, or a threat to others. So about 45% of all calls we go on lead to a crisis assessment. And from there, if a counselor, has to do a crisis assessment, they build rapport quickly. They try to get a full history from the person if they're capable of the full mental health history, what's leading to this crisis, what does this person need in the moment, kind of building that trust. Then they'll talk to family, friends, anybody who has collateral, whoever called 911, if someone called 911, to figure out what's going on and get a whole picture of the situation so we can make the best clinical decision for their treatment possible. And then at that point, that person is a partner with, that consumer is what we call people that we try to help. That consumer is part of the process. So at any chance we get, we try to make them part of the decision-making process of what kind of help that they want and what kind of help that they need. This could be a safety plan with their family, someone whose depression has increased, but they want to try to get an appointment next week. We'll make a plan with the family to keep them safe. It could be just connecting them with their outpatient provider. It could be coming down to our crisis treatment center and beginning treatment immediately, or our crisis stabilization unit. All the way up to, maybe going to the hospital. And then in the very worst case scenario, and things we try to avoid, is going to the hospital involuntarily. But we have all of those options at our disposal to try to get people the treatment that they need. That's really what a crisis assessment entails. So like about 40% of that is that. Most of the calls will build rapport, we'll de-escalate. We'll try to connect people to resources. Some people refuse resources, say, I don't need help right now. It's not a situation where we have to force them to get treatment. So we're trying to get people to collaborate with us to get the best help they can. So some people, they maybe not ready for those resources. They'll take the numbers. They're like, I want this help, but not today. I'll call them in my own time. And then if we see them multiple times, sometimes we have to, we'll build that relationship where they'll finally be able to come in and get help. That's pretty much an overview about like what the day-to-day is like. I just got off a call here because I'm actually working in a police car today. And what the call we got on was someone was texting 911 over and over again, and the messages were getting very bizarre but concerning. So our car and a couple of other cars went out to the apartment complex, and we were able to make contact with the individual who really wanted to talk to us. Excuse me. And, that individual immediately said that, he was receiving messages through music videos. He was very upset and angry about these messages. He actually really attached to our CIT officer, our partners in care officer that I'm writing with. He wanted to talk to the officer more than me. So I had the information I needed. I was able to go talk to his family and call his mom and get more information about his history. And we are currently trying to get him placed into treatment right now. So that's kind of the call I'm on, I'm kind of wrapping up now, but those are kind of like our typical calls here.
And Mike, I like to interject. One of the things that I was impressed upon, that really impressed me, was the fact that the officers So the officers volunteer for this duty. And so we come in, I mean, we have one afternoon out of the 40-hour weeks. We spend one afternoon, and we have family members who have had to call the police in a mental health crisis. And we've also had, and always try to have someone who has been, taken in by a police officer. And they share what was good about what happened, what was maybe bad about what happened, and, and give suggestions and help the officers and are there for questions. But I think what really impressed me about the officers and doing this particular program was I also serve on the Partner in Care's task force, which quarterly we just had you might have seen it on the news, where we just had a report out yesterday. Mike is a big part of that, and so are some other folks. And so I remember distinctly after the first one of the officers, I think it was one of the supervisors, came up and said, we go on all kinds of calls. And, and we're used to just responding to what we see. He said, but when I started riding with one of the mental health workers, he said, I remember we would stop and I would stand there and be talking to someone we were called out for. And I would talk to that individual and I think, just a dry case. This is what this case is. No problem. But my partner, my collaborative partner, the mental health worker with me would go, would you mind, can we hold on a second here? I'd just like to ask, have a little conversation here, ask a few more questions. And so because of the training and the experience that this person has, they were picking up on some body language. They were picking up on content. The officer got the content of the words, but the crisis worker was picking up inflection and different things that they're going to be used to. And so the officer said, I listened and watched what's been happening, and not just over one call, but over several calls. He said, and now I know how to listen differently. I understand things differently. I didn't know to do that before. This wasn't something I was exposed to before, but now I know there could be more than what I'm seeing. And so I think this is an important part. If we were looking to change hearts and minds in our officers, this is a way to do it.
Yeah, Robin, that's a great point. I think one of my proudest moments as a trainer, or so far in the program, is I was in the car. These are just anecdotal stories about when I'm in the car 2 days a week. We got called by another officer who is one of the officers in our program, so got the training. And he called me on my cell phone, called our car. He was very specific, where he said, hey, I'm on this call, and the call went out like this, like a domestic, but he's like, I think this person, due to pressured speech and some, psychomotor agitation and not sleeping, I think this person is bipolar in a manic episode, and you might need to come talk to them. And I went out there, and it's exactly what it was. And he used the right terminology, picked up on the right symptoms. And I was like, this is very impressive. You're doing a great job.
Yeah. And what's really cool is they're coming back to their precincts and they're telling other officers. I think, Mike, haven't you guys had some volunteers that have been other officers that have asked to be able to volunteer for this program as a result?
Yeah. In Hermitage and North, I think there was, it's a pilot program. There was apprehension, obviously, in police culture about it. And then once we get started about 1 or 2 months in, we started having other officers in the details we work with, like, hey, I want to go through that program. I really like what your car is doing, what the program's doing. I had one officer, first name Rex. He was like, I spent some time with him on other calls, and I was like, hey, Rex, you're really good with empathy and talking to people. I think you would really like this training, and I think you would really like this work. And he said, really? Thank you. I would really like to do it. And he went through the next one. That we actually sent him out of county to get him certified as soon as possible because he volunteered and was so interested in it.
Mm-hmm. And so it's really important to do that. I see a question in the chat. How soon can this be expanded to the whole city? And it's a pilot program. We've got the funding. We actually, Mike, I think you can speak to that a little bit more, because I know that I know we're already expanding because we found it to be so effective. But but we will need to have more funding so we can be able to do more with this. Inspector Imhoff, if you want to talk a little bit about him, because he is so key to this program.
Inspector Imhoff is my counterpart in the Office of Alternative Policing Strategies. Him and now he has Lieutenant Brooks, who also works in our program. He's also very great. But for the first few months, it was me and Inspector Imhoff kind of planning this all out, mapping it out. And we were able to streamline, problem solve a lot of these problems that come up in systems level processes. You know, we're a mental health nonprofit. You know, they're a police department. So there's a lot of things about getting agencies working together to get this program off the ground that you don't think about until you start doing it. But Inspector Imhoff and I have gone back some ways. We were actually friends without, I didn't even know he was a police officer. He didn't know I was a mental health professional. We actually used to box together at a gym. And then we started doing this program like 7 years later. And we're like, oh, it's you. And so I actually helped him apply for his graduate school where he got his master's in mental health counseling. So he's very passionate about mental health and helping people in mental health crisis. For expansion, I believe we're going to expand to 1 and 2 precincts by the end of the year. And we're kind of using our data to drive where we expand first, where the need is for the city the most. Right now, it's Monday through Friday, like I said, 6:30 to midnight. And something I didn't talk about is our clinicians. They're all master's level. Most of them are licensed professional counselors or licensed social workers, or they are trying to achieve licensure. We also sent them to the police academy to get some special training for a few days because obviously our clinicians were worried about being in a police car. What's it like out there? You know, no one in the city has done this kind of work before, so we didn't really know what to expect. But I did know that I wanted to minimize arguments in the field between a counselor and a police officer to really facilitate that partnership. So we had them learn about what state laws officers have discretion to not charge people on, and what state laws they have to, you know, arrest on. So there's no arguments about that. We taught them how to use the police radio, because we carry a police radio just for emergencies and when we're in the police car. And then and learning the terminology and things of that nature. They also learn their ethics, their kind of decision-making model, and the standards and professional standards they're held to. So we know if any problems arise, that we're able to take care of it. We also learn about situational awareness and cover and safety. So safety is a major concept for this program of keeping clinicians safe, keeping consumers safe, and keeping officers safe. So there's a lot of focus on training and safety, and that officer is the person in charge of safety. If they tell you to stay in the car, or they tell you to go back, you know, we listen. That's how our counselors are trained, because the last thing we want is anybody hurt accidental.
Thank you, Mike. And at NAMI, what we do is we actually have trainings for families and for people with lived experience. And on that safety issue that you're talking about. So we have an 8-session intensive that we do specifically for family members, helping them to understand what mental health conditions are, what treatments are, and that medication is not magic, and it's not the only tool in the toolbox. There are others. And that we, you know, teach them, if you are in a situation where you're going to have to call 911, here are the things they need to know. And then we also impress that officer is responsible for safety on the scene, but this is what you can help if you have to have a situation where you do this. And so that is very helpful. We also teach them how to communicate in a way that might be a little different than they're used to with their loved one. And we do a pre and post test for this class. It's an evidence-based signature program of NAMI nationally. And we know that 90% of the people coming out of that class are learning to better communicate with someone with a mental health condition. 80% of them have a reduction of crisis in the home, and 90% of them are taking better care of themselves as caregivers. When we go into Mike's program and talk to them, we have, you know, it's actually a sibling. She's an older lady with a brother that's had mental health conditions since he was 8 years old. And so one of the things she'll always stress to the officers is, please be sure to make a report every time you come out, because even though you're coming out this time and that person may stay put, and that's fine, sometimes there can be a series of incidents where the police have to be called, and it may be a time where you know, they need to know that this isn't a one-time thing. In their records, they can look back and see, there's something going on, or maybe they can help them to understand that he's escalating. So those things can be really, really helpful. And then we encourage the officers to send people, let them know about the free support groups we do, and the free classes, so that people can be better educated, because sometimes, and folks, we know that sometimes there are toxic families. We understand that too. And that can be very difficult on somebody with a mental health condition. And not everybody is in a family. Mike, I think one of the things that when we received the information from Katie yesterday, was I thought the percentage of homeless people that you guys interact with out of all your calls, I believe was about close to 8%. And I thought it might even be higher, but it wasn't. In fact, I do have some notes from yesterday from Katie's presentation, and just kind of breaking down where we are, that 25 to 34-year-olds was the largest group. 65% of the people you interacted with were white. 61% were Davidson County residents. So that's a large group that is not. 8% were homeless. And then the breakdowns were proportionate to the population of Davidson County. And I thought I asked a question during the meeting yesterday, issues by gender were 50-50. And I thought it would weigh more with guys, because it's something we often see, but I guess you guys are just really seeing it kind of 50-50, the person with the condition across the board. There seemed to be, and you guys, they have a map, they have a heat map to show where, they're getting the most calls. And I thought it was significant that one of those places was in North Nashville, and it was a much tighter area than we saw in Hermitage. And I think, Mike, that your response was, that's where we have the most group homes.
Well, not just group homes. That's the highest population density in North Precinct.
There we
and
go.
North Precinct is kind of like the North Nashville city area, and then above that is like Ashland City, Jolton kind of area there. So there's much less calls for service in that area overall, and most of the population in that precinct is concentrated in that area as well.
Is condensed. So these, it's really interesting, and all of you, I mean, this information is being published by the health department. It's their epidemiologists that are tracking it. And so, and somebody's got a question in the chat. Do you keep data on whether people are insured for healthcare? I'm not sure that data is being kept. I know that, you're helping people regardless, and I'm sure it's part of the behavioral health safety net and other things that are available. But if you have an answer to that, Mike, could you share that, please?
Yeah, I think the data is being tracked, but it's not, I'm not the data guru guy. It's never been my strength area. We have an epidemiologist with the health department who collects our data, and it's all, health privacy information. So it's protected. Anyone we see, they never get charged for services or anything of that nature. And I believe that we could probably get that statistic going. It is a pilot program, so we're kind of adding data points every time we kind of do a data gathering meeting where, this would be a good data point to collect. And we kind of have to go into the back end and kind of change the report and get more data that way. I did want to add that when we were building this program, because we're really building, and Partners in Care is like a citywide future crisis continuum. So at the table, we're not just police and mental health cooperative. It was Hub Nashville. It's the health department. It's the fire department. It's emergency dispatch. And I think the dispatch is a good area to touch on here, because they've changed the way they've started taking calls for service with mental health. They're asking more questions. They're able to kind of get some more information to figure out if this is a mental health crisis or not, and not just, someone's trespassing down the street, or someone might be suicidal, or someone might have a knife, and kind of getting more information about that so we can better respond to crises in the city. And one of the reasons we picked Denver as the model because they have such a robust crisis continuum. They have a co-response program with police for higher acuity crises. They also have a non-law enforcement response for lower acuity crises. And those teams are able to work together and kind of refer back and forth depending on the situation and get people the correct care and the correct response they need.
And I'm going to do, thank you, Mike. I'm going to do a quick check. Carol, how are we on time? You're on mute.
You have almost another half hour.
Oh, excellent. Okay. So, because I've noticed that Katie is on, and I also noticed that Amanda Bracht is on, and so they, each one of them may have something to contribute. But something I wanted to contribute outside of this program is I have been in touch with Lieutenant Gooch at the police department, who's part of their well-being program, and we met like 6 years ago, and they were he's an officer. He was an officer who had issues where he developed PTSD on the job. And so he wanted to develop support groups within the department. And he and I had a few conversations at that time because he knew that we did support groups. And so we kind of lost touch. We'd been trying to connect with each other during COVID, and every time we were set to connect, somebody, there was some kind of COVID complication. It just didn't work, but we finally were able to do a Zoom call together, and he has just really taken on that program. And I'm just so delighted. But what I want you to know about the program that is there for officers and family members of officers is that their goal is to allow officers to be the best they can be going out the door. And, there is a whole lot. They're people, first of all. These are human beings. They're just like you and me. They have families. They have family issues. They have their own, issues and struggles. And so, but when they get out the door, they're faced with so much more. And they work and are there for the support of those officers so that they can be the best they can be and a clean slate going out that door whenever possible. And so I was just so impressed by the incredible growth of that program and what they're continuing to do with that program. And so I just see that as an adjunct. I want you to know that you've got these officers that have volunteered for Partners in Care. And then you have, behind the scenes, you've got this other section that is there also helping all police officers. It's available to them if they want to make use of it. I think that is a really important thing. At this time, Katie, I want to take you up on your offer there. Katie is here. She's an epidemiologist with the health department. She was one of the main presenters yesterday, and I'm sure these folks would love to hear about some of the data that you shared with us yesterday.
Thank you so much. Yeah. As stated earlier, about 44% of all of Q1 and Q2, or just Q2, I apologize, events were required a crisis assessment. And Michael went into that a good bit. A significantly higher proportion in Q2 as compared to Q1 of events resulted in some sort of hospitalization, whether that be transport to ER or transport to the hospital. So that was definitely an interesting statistic that we found. And yes, the majority of consumers were stably housed, either renting or owning. And actually about 22.3% were found to be unhoused or in temporary emergency housing. And 7.6% were in group or transitional homes. And as was stated earlier, yes, North had a higher proportion of those in group or transitional homes, while Hermitage had a higher proportion of those in who were unhoused or in temporary emergency housing. And yes, the largest proportion was aged 25 to 34, but the average age was 41 years overall for demographics. And yeah, that's, I think I have an estimate of those who are insured. So we don't have complete information on everyone for insurance status, but we are aware of about 35% of quarter one and quarter two's insurance status, and they did have some form of insurance for about 35%. And the rest we don't have confirmation on. So
Hey, Katie, we've got a question in the chat that is our data similar to Denver's or other cities trying something similar? And someone raising the question, you know, because we'd love to see this scale up nationwide. And I should tell you that, you know, as an executive director of NAMI Davidson County, I'm in a national network of executive directors across the country for NAMIs. And so we know, just as Mike knows, and probably now Katie knows, because she's gotten involved in this, there are efforts going on around the country. You're seeing more and more of these efforts go on around the country. But I do see, the question is, Katie, is this similar to Denver's or other cities trying something similar? And can you respond to that?
yeah, so Amanda or Michael, feel free to jump in here. But as far as I know, we have actually had quite a few more events than Denver, and Denver was citywide, as compared to us just in 2 precincts, 2 really of 8 or 9 precincts. So a very small proportion of our county did have far more events than Denver was seeing. So.
Thank you, Katie. There's another question in the chat. What are the benefits of a co-response model as opposed to the model set forth by NOAA? And that model is the HEALS model. And will there be a delineation of those responses going forth? So for those of you that may not be familiar with the HEALS model sets up so that you have only crisis workers and EMTs, or it's a medical model going out. And it does not involve the police. You know, I've had conversations with others on this where we have said, you know, we know there's room for both, not one or the other. We absolutely know there's room for both. Some of you may be familiar with the fact that 988 is coming in, and 988 will be a number that you will be able to call when you have a mental health crisis. As opposed to 911, you would call 988. And immediately a dispatcher would know that's, you know, related to mental health. That's why the person called that number. It'll be slowly operationalized. I know the first time it's going to come out, I believe it's supposed to be in July of this year. And at that time, it'll be answered by the National Suicide Prevention number. But eventually, when it gets fully operational, it'll come into here and we'll be able to use that number. And dispatch is doing a great job, by the way, of beginning to nuance these calls as they're learning things too. They're beginning to understand things. And so they're kind of directing calls, you know, with more knowledge of mental health when they can, and letting the team or whoever they're dispatching to know. But yeah, we see, you know, me personally, I'll speak for myself, and I'll let maybe Amanda or Mike speak to the fact that, you know, we definitely see room for both models. We always want the thing that is going to be, you know, least triggering to the individual involved. And you don't always need a hammer, you know, to take care of a situation. And so I think when we can, I certainly see room for both. But Mike or Amanda, I'll let you guys speak to that.
Yeah, I'd love to speak to this, because I think it's such an important and great question. I think one of the main differences between like a non-law enforcement co-response program and like a Kahoot style medic and mental health professional, that is, if there's an imminent danger to self or others, or a weapon involved in the call text, or anything's mentioned like that to the dispatcher, they won't send a non-law enforcement response to that. They would send a police officer. So in our city, we need to all come together and kind of discuss. So like if someone's in an acute crisis and has a weapon or is agitated, or someone feels threatened, to have multiple programs, because I think if we're going to have to send law enforcement on some of these calls, they need to be the best prepared with training, have clinicians available right there on the scene, and give first responders, fire, police, all the tools that they need to de-escalate that situation, and all the tools for that person in crisis to come to a safe outcome. As opposed, if they don't have a weapon and they're not agitated and they really want help, and there's a lot of crises that deal with that too, a non-co-response model or a non-law enforcement response would be a great response to a crisis like that as well. So that's why I've always said from the beginning, I love Denver because it has a full crisis continuum plus treatment and wraparound services afterwards to keep people out of crisis and getting help.
And Mike, I think you just said something really key there. Please don't think that that's a minor point that he just ended with, because the truth of the matter is we've got to have this. This is not a police program. All right. The police are the beginning of this program, and so once these folks are brought into care, it's great. And I think one of the things that's been brought up in the statistics are that people are being introduced to care and care models that have not been in the system before. A lot of the folks that we're seeing have not had a relationship with any of the systems that we have for mental health care, which is good. I'm glad we're getting them there. But it also goes to show you that we need to make sure that the services that we have are robust. And the mental health cooperative, through their crisis stabilization unit, through their crisis services, is really doing a great job in doing that, but they don't do it alone. We have other providers in the area. We've got to make sure that from a NAMI perspective, we're very interested in insurance parity and making sure that people are being treated equitably within their insurance policies, and they are not being turned away for reasons when they should be covered. And so different issues. Case management was something that we had 5 years ago, and case management, we now have care management, which is a little bit different and can make a difference in the lives of the people being served. So when we come out to you at NAMI on an advocacy platform that is legislative and policy oriented, the more you want to know, we'll let you know. We want your response to this. If we're asking you to help support something, the budget at the commissioner's office, we're asking you to help support that or a particular issue. And this includes, it's not just mental health. When I'm talking mental health, please understand that I am automatically including substance use disorders, and because they are tied. They are absolutely tied. So it's really, really important. And so somebody noted Colorado expanded the ACA. Wow, it would really be nice if we were a Medicaid state. Just saying, folks. It would make a darn bit of difference if that were the case. Just going to share that. We know we would be able to treat more people. We know that is what is being to address how race affects encounters between consumers, police, and mental health workers. And so, Mike, I'll let you speak to that, and then I'll talk about our programs of multicultural outreach.
Yeah, I think that's a great question. The pilot started very quickly. We had about 3 or 4 months to kind of get it up and going. We took clinicians currently working for mobile crisis with an average tenure of 8 years. Most of my staff is female. Most of my staff is white. We have 2 males, 4 females, 1 African-American female. And I think there is an importance of giving people options to be treated by people of their excuse me, getting over an upper respiratory infection. Their culture, their, someone that they feel comfortable with, familiar with, and addressing those issues is super important with diversity, and with different areas of town are going to have different needs. And that is something that we are planning with the future, with the expansion of matching people up. When we get call texts from like a call from dispatch, which is like 85% of the calls, we don't know off the top of our hand what race someone will be when we get there. So it can be challenging. But really, people deserve the help that they want and the help that they connect with. So we are trying our best to meet those issues. And really, we're inviting community partners to kind of help us, solve some of those issues.
And Mike, we had a really good example yesterday of,
Mhm.
one of your folks that was bilingual and really made a big difference in a call that you were working that was quite convoluted, and there was quite a lot to it. And the fact that she was bilingual made all the difference in the world, sounds like. So that was terrific. We will say at NAMI, we recognize that, there is a lot of cultural difference in the way that people perceive mental health. And so in our services, we try to build peers within communities. So we've been very active in the African-American community for 8 years and serve on the suicide prevention in the African-American Faith Coalition, because we know the best way to reach that community is through churches. And if a minister starts speaking mental health from the pulpit, then people will listen. So that is definitely one way. We just recently did a survey in the API community and collaborated with the Chinese American Association and API of Tennessee so that we could get a handle on attitudes in the that particular community. And when we did that, we were informed by our partners that we never used the words mental health in that survey whatsoever. We only referred to stress because more than likely they would not respond. So we, and we're working to, and we had an intern who was working to see what resources were available that were culturally competent within that community. And there are very few within that community. We already have partners in the Eastern Indian community, and we have been invited recently through a collaboration that we have into the Muslim community and working there. And so people are going to be more comfortable with people that look and sound like them. And we have so many diverse populations here. We have worked, as has the Mental Health Cooperative, with people who are Kurdish and Korean and Egyptian and Nepalese and Hispanic and Filipino and just this is Nashville. We are a diverse community. And so, and the LGBTQ community is a culture, and age is a culture. And there are closed cultures of strength like veterans and the police department. So, and youth. So, we look at, these are all diverse cultures and they all have different ways of approaching mental health. I think what we've got started here is a fantastic start, and I look forward to more of it. I love Benita, I don't know, Kamowitz looks like, and said stress might actually be less stigmatizing word than mental health in any community. I agree with you, and I will tell you, in NAMI Davidson, when we hold our groups, we call it stuff. And it doesn't matter what your stuff is. You may not have a diagnosis for it. You just know it's impacting your life. And I don't care who you are, you got stuff. I don't care if you've got papers with it or not. So that's how we approach it at NAMI Davidson. You got stuff. And at this time, I'm just going to say really quickly, and then I'll respond to any others and let our other speakers know. I'm going to put my information in the chat for anyone that would like it. And so, we've just got a little bit more time available. What other questions might you have for us?
Thank you so very, very much, Robin. I actually have a question, and my question is, are you seeing the impact of gentrification in the two areas where you're working, creating more mental health issues for individuals that live in those two areas?
Mike, I don't know about that. I'm going to respond to that by saying where I see it. And because I also serve, I've just stepped down from leadership of the Region 4 Mental Health Planning and Policy Council. And we do a needs assessment every year. We're involved in that every year. And housing, group home housing has been incredibly impacted by gentrification, because with the rise in what people can get for houses, group homes are being sold out from under the people in them. And we really are, guys, we have people who may have reached their potential in their well-being, or are on their way to another stage as they're processing through and figuring out their conditions. But we need housing. We need housing for these folks. And that gentrification, that, the changes that we've had here in Nashville are sorely impacting that.
Thank you.
It's going to be hard for me to answer that based on Partners in Care, because we've only been doing it for 6 months with that data. I will say that I have been working at Mobile Crisis and Mental Health Cooperative for 13 years. So I can say I have, in my crisis work in my career, watched, as Robin has touched on, these housing options kind of dry up as we've gone on, like less and less group homes, less and less transitional housing. And it can be a real challenge when someone's major stressor is, and this is someone who might get a disability check because they might have severe and persistent mental illness, to find a place to live.
Mm-hmm. Absolutely. And it's not just the group homes. It's the, sometimes it's independent housing. Somebody gets a Section 8 voucher. Where are they using it? Yeah. I mean, okay, I've got this voucher. Where do I go with it? Because, affordable housing in Davidson County is getting to be really, really tough. And then when you do get outside of Davidson County, we are fairly rich in the resources to help people along with their mental health conditions. But, once you get outside of that, in Cheatham and Robertson and other areas, there are some, and they work hard, but they're not nearly as plentiful and not as targeted as what you can find here. And so you force these people out, and then how are they going to get back in to get their treatment? And then you wonder why they don't get better. It's because we focus on a disease model and not a recovery model. We need to focus more on helping them get better.
Thank you very, very much. That's helpful information for us to have. I think judging from the questions that you have gotten, I think that you have had a tremendous number of folks with a pretty strong interest in what you're doing. And I am delighted that you have taken an opportunity to share with us all the things that you're doing. And it's a lot more than I thought you were doing. So I have certainly learned from this process too. Mike, Robin, thank you both so very, very much. And I want to say to our group as a whole, we're trying to continue to have good programs for you. If you have an idea about a future program that you'd like to see us present, please send it to me or send it to Karen. We would love to take your ideas and run with them if possible. Our next program, I think, is going to be a dynamite program, considering what's been going on in our country. And we are fortunate to have a scholar from Vanderbilt, Vanessa Beasley, who also happens to be vice provost, present in an area where she is known as a national expert on, from a historical perspective and for present day, the impact of presidential rhetoric on what's going on in our country, going all the way back to, I think, about 1810. So it's going to be an interesting program by a person that I think is an exceptional speaker. And I have to make one confession. 100 years ago, when she was a sophomore, I taught her at Vanderbilt in the Communication Studies Department. So I'm going to take a little teeny bit of credit for how good she is at what she does. Not really. But anyway, we will look forward to seeing many of you next time around. And I think that unless there are other announcements that somebody needs to make, I think we're coming close to the end of our hour.
So someone did come in late and was asking how to get and when to get the recording of this meeting. All of our hot topics that we have had for a number of years, there we go, are available on our website. And it usually is about 3 days to a week post the hot topic, that the video is available on that website, or a link to the video is available on that website. So if anybody needs that information, I actually, one person did ask directly, but I can, maybe someone could quickly put in our website, since I don't know it offhand, and I don't, this isn't my computer.
Hey, thank
It's
you all
like-
for having me. I actually have to get going. There's a
Okay.
situation, but I
Oh,
really
please.
appreciate you guys.
Mike,
Thank you
thank
so
you
much.
very,
so
very,
much. That
very
was
much.
fantastic.
Take care, Mike.
Okay, so, any other?
Robin,
Yes.
thank you
Thank
And-
you.
and
so
thank
much.
very,
you all.
very much.
Yeah, thank you, guys. We
And
were,
keep us in your loop.
And Katie too, who popped in. Thank you
Yeah.
so much for
Yes.
that. You, just amazing that you had so many of you all from
Yeah.
your side.
Yeah.
Thank you.
thanks, Scott.
Thank you.
8 new messages. Oops.
8 news.
Well, it's because